So Andrew, I don't know if you've interacted with the audience in India at any point, but it's the work you do is so important. I've had them follow you on social media, and I got to meet you in San Diego and hear your work. And I've heard so much about you from the SMHP team, and so everybody who's listening, the SMHP is the Low Carb USA. So that's the metabolic health practitioners group that is mostly US, but it's definitely international. And Andrew's work he's done, actually, Andrew, why don't you tell us? I would love to hear your journey, and I'm gonna not do it as well as you can. Is tell us how this work came to matter to you.
So I have actually interacted with some groups in India before, actually Blue Circle Health Foundation or Diabetes Foundation, if you guys are familiar with them. So yeah, so I've had that opportunity. I haven't been there. That'd be really cool when the opportunity comes to actually do that. But my journey into kind of speaking with you guys here today is a long-winded one, but I'll keep it pretty short. I started when I was a kid, 10, 11, 12, I actually developed obesity. So I had obesity as a kid, and I had it for years. Actually, I tried a number of different strategies to lose weight and failed numerous times. It's not the easiest thing to do if you've ever been on that journey before, and finally was successful, but completely independently of that. What that had taught me was that lifestyle had a pretty profound impact on not only how you look, but also how you feel. Yeah, but exercise and nutrition combined, those were really the tools, the only real tools that I was using at that time. And what most people generally think of when they think of what is a tool I can apply to, manage something like obesity without going to the doctor getting medication, which is an option. But a year later, completely independent of that journey, at least it appears to be completely independent, was I got diagnosed with type 1 diabetes a year later. And that took everything to a completely different level, because then every single meal of every single day, I was monitoring what I was eating. I essentially had to instantly become a world expert on nutrition just to manage my own life, not to be a researcher, not to be anything else, just to manage it. You had to know everything you're consuming. I remember the first day I walked out of the hospital, I looked at the menu and there was all these food items, and I'm like, I have no idea what the ingredients are in these things and how many carbs it has and how much protein and fat. That was foreign to me at that stage. But you you have no real choice in type 1 diabetes but to learn that very quickly. And so that really took me on a journey to then begin studying this. I was really passionate about lifestyle nutrition. Getting type 1 diabetes took that to a completely different level. Like my quality of life, how I felt was, and then my overall long-term health was completely dictated by these decisions every single day. And then I took the path to say, hey, it would be really cool to actually study what's actually happening. I eat this food, it changes my blood sugar. I lift weights, this happens. I might feel better or I get stronger, but what is the actual underlying physiology and biology that is actually driving that? And what I found is that when I coupled my own life experience, which frankly was the best teacher I've ever had on health and nutrition and metabolism, and applied that with the underlying understanding and knowledge we had accumulated that at this point about why the body responds to food or exercise, that really created this amazing opportunity and journey to then research it and try to answer questions we hadn't answered before. And that was I became really fascinated in the idea of how do we regulate. In the case of type 1 diabetes, one of the biggest levers or therapeutic things you can do is changing nutrition, because things like, if carbohydrates or is at the second you eat those, it instantly releases blood glucose and you're instantly having to manage that with insulin. And you're kind of playing this constant game all day to do that. And so I was really fascinated about what happens when you change your nutrition strategy. If it is the biggest factor in our lifestyle of regulating how we feel, what happens if we change that? And so we've done a number of studies over the last 15 years now, actually studying the interaction between food, how food changes our whole body and our metabolism, and how those metabolic changes actually translate not only to various diseases. This could include things like diabetes in my case, to neurological disorders, to things like we've studied special operation environments. So, for example, when we did a study for Special Operations Command in the United States of America, where we actually looked at strategies for extreme environments. So if you were to be exposed to hypoxia, what happens when you utilize some of these same strategies? We think almost exclusively towards, with this lens of health, how do they apply in these other settings where our body is stressed? And that has really led to a pantheon or a spectrum of two different extremes that I'm really passionate about in research, which is helping the person who has a metabolic disease, a complex metabolic disease, and utilizing what seem like very simple solutions, but understanding how they affect and change ultimately outcomes, the patient's quality of life, but real outcomes. In the case of type 1 diabetes, we're talking about glycemic control or the amount of insulin you have to take every single day. Or in the other end of the spectrum, looking at these elite level performers, where we've done a number of studies looking at applying this molecule that elevates on a ketogenic diet or low carb diet called ketone bodies in these, high level performing athletes, understanding how it may change metabolism also just by applying those to looking at high end triathletes and runners, and how does changing diet affect performance, but then also affect health and metabolism. So I've been on this journey for 15 years now, kind of exploring this on a personal level, but also really diving in deep to understand how it may apply to other domains outside of my own personal situation. And that's what really led me to be a researcher and take this journey on nutrition.
My gosh. I mean, you didn't stop at just solving it for yourself, right? Here you are adding value to everybody else's life. So it's amazing, Andrew. And I know you're still going to do more, right? You're still so busy with what extra projects you're taking on. And I'm sure there's lots of projects you're working on. I know some of the audience right now is following a mostly ketogenic diet, but I would say many of the people here are not. Some of the audience today is vegetarian, some are vegan, and some are on pumps, and some are on shots like pens. So we have one person who has been on insulin since the time that she had to boil syringes and get pork insulin.
That's cool.
Yeah. So there's quite the spectrum of experience, life experience in this audience, because, what I found fascinating about your journey is you've gone deep into not just the theory of telling people. We see your lifestyle and we see your food choices, we see your graphs, and as much as it's frustrating to have to look at being in range, the amount of almost like perfection that comes with trying to live healthy with type 1, you do it so gracefully that I want this audience to get anything from today, from talking to you. I use carbohydrate-based snacks to prevent a hypo during exercise. But Andrew, what have you kind of summarized it, but specifically the food and exercise interaction, carbohydrate-based snacks to prevent a hypo.
So so anytime someone with type 1 diabetes has hypoglycemia, the first tool and strategy you're taught about to manage that is to increase it with rapid acting carbohydrates. And they essentially tell you could really do anything, right? You could have orange juice, you could have bread, you could have pure dextrose tablets. My experience with exercise is, and talking with a lot of athletes, and having worked with a lot of athletes actually who have type 1 diabetes, what you find is that and I'll tell my personal journey first. So when I was on a high carbohydrate based approach, and I was for the first 5 or 6 years upon diagnosis, exercise was one of the biggest challenges because I had really rigid scheduling and all these other things that when I was younger in life, things have totally changed now, but I had this really rigid structure. And what I found is that exercise would induce a very rapid flux in glucose levels and or insulin changes. And now in the context of type 1 diabetes, I want to at least describe that when people think about insulin, they think about insulin sensitivity or changes. They're almost always thinking insulin sensitivity. If I need less insulin, or my insulin levels go down. I'm much more sensitive. But in the context of type 1 diabetes, there's another layer to that, which is you're administering. So I think on, let's see, on this arm right here, you're administering insulin for the periphery. And so there's a time lag between it getting here to actually getting into systemic circulation. But when you exercise, it increases the absorption rate. And so it's not just insulin sensitivity, which does change post exercise, but it's also how quickly your body is now pushing blood flow to that area where the insulin is being administered and taking it into the bloodstream, and the heart rate circulating it faster. So it's actually a lot like taking an insulin kinetics curve like this and shrinking it. So you're actually, the peak is higher and it's earlier. And so that's why a lot of people experience flux during exercise, which can be hard to manage. What I have found personally is that one of the most successful strategies in exercise is, yes, if you have a hypoglycemic moment, the most obvious and helpful thing you can possibly do for yourself is not sit there or stay there. Maybe even anticipate, if you have some routine in your life, if you know you're about to go hypo, giving yourself something to prevent that is obviously essentially important. I personally always use dextrose. You have these like chalky tablets you can buy at a medical counter. I don't know if that's the same way in India. They typically cost a little bit more than buying something like, I don't know if I have one on me right now, but Smarties tablets. I don't know if they have those in India or something like it. They're the same exact thing. They're way cheaper. They taste better, and they also are instant. One problem I have found over the years is that when I start using like a dried fruit, or like real fruit, or bread, or some type of juice, it's very hard to the any type of food is going to take a little bit more time to digest than pure dextrose. That's number one. And if you have a drink, it's also hard to be very prescriptive with only bringing your blood sugar up enough to get you where you want to be and stay there. Because a lot of times what's happening in type 1 diabetes for many people is they're constantly like almost like combating this. You're almost on a wave. You're in the ocean, you're on a wave, and you're never off the wave. You're just trying to shrink the wave. And so one thing that I found very helpful is that I use pure dextrose instantly to bring it up just to the level I think will keep me stable. Not to, I try never to overreact, although I have plenty of times. I have, in type 1 diabetes, when you have that stress response and you feel anxious and you want to correct it immediately, your body is telling you, take something quickly, take as much as you can. But I try to be very careful to only bring it up to where I need to, because then I can stay at this perfect spot, instead of going higher and then I'm now fighting that again to go low. So I try to use something like pure dextrose, and you can buy those over the counter, at least here in America, at a pharmacy or a drugstore. But you can also just buy candies that are pure dextrose, and they're so fast. One thing I've also found is that when you have a lot of food in your system, so let's say you just ate food, and this is outside of exercise, this is just correcting hypos in general. If you have food in your system, let's say you do eat a low carbohydrate based approach, or don't, or let's say you eat a vegan approach that's higher in fiber, although fiber is good generally speaking, but across diets. But let's say you had a high fiber diet and it's still digesting. If you eat, let's say, an orange on top of that, it still has to digest that down, and you have other food in your system, in your stomach, that also needs to be digested as well. It's going to be slower. Whereas you take dextrose, it's already being broken down in the mouth. It gets to the stomach. It's basically pure. It doesn't require all the digestive steps to instantly be absorbed. So it allows for you to correct hypos even when you have other food in your system and still digesting things. It's much more quick, and it allows you to be very prescriptive. You have this little sugar tablets, and you can just say, I want this much, and I can take one of these or two of these and just do it. Whereas if you had like an orange juice or a drink, you could drink half of that and not realize how many carbs you actually consumed, and it's unpredictable. So I like predictability. It ultimately makes life easier to manage with the disease.
So important. I learned something there, even though, I don't live with this. And so there's textbook knowledge and then there's your experience, right? And what you just said, just the kinetics graph changing with blood flow increasing, The only time a doctor is taught to think about absorption from a skin site is when they're in the ICU and their blood pressure is low and IV insulin or subcutaneous insulin is not going well into the skin in somebody who's sick, you know? So we haven't translated that into the healthy person with type 1 who is exercising and is fine, but they have this delivery going on over here that just, it's the same exact thing, but on the flip side, you know?
A lot of things change in the context of exercise, and I could probably speak to you guys on this for hours. So but I'll be very brief and then open it up for like relevant questions you guys may or may not have, or any questions you guys are thinking about. There are a lot of things that change the kinetics of insulin. Injection site is a big important one, whereas the leg tends to be slower than other areas of the body, like the stomach or the arm. In my personal experience, the stomach and the arm tends to be the fastest, but I've also used tools, not saying that is just my experience. I'm not giving anyone any clinical advice here, but I've also done injections when I'm trying to just, when I do a low carbohydrate style approach. And what I found is that I'm able to stay in really tight range most of the time. And if I start to come up, I can predict that and make a correction. If I'm starting to go low, I can just have, a quick little a dextrose tab to stabilize it out. And I can stay in that range. So I'm not constantly trying to like knock it down, up and down. So that really helps a lot. But when I'm trying to correct a high, a lot of times I'm not just thinking about injection site. I'm also thinking, should I inject it into the fat or the muscle? And when you inject it into the muscle, you're also shrinking the time, right? Because fat is slower digest or absorption, and the muscle is also quicker absorption. So there's different tools and strategies that people can actually use to take a kinetics curve that's just, oh, look, you're sitting, and it has when we think about these kinetics curves, by the way, this is important to mention, and I hope they're not confusing one by tangenting here. There's this ultra rapid insulin that most people use to correct for meals. And you have this basal insulin that is often used to give a stable level of insulin to correct just the amount of glucose put into your system from the liver. Now, some people are on automated insulin delivery, I'm assuming, maybe potentially here. And so there might be some automation to what some people are doing. When you have something like exercise, and specifically, this is very relevant in multiple daily injection approach, where you're actually injecting insulin or using a pump, especially with a pump, because with a pump, you're putting into a single site here, especially when you have multiple days of use on that pump site. You can actually have some accumulation of insulin at that site that's not being absorbed as well. And when you start really being active, you can instantly absorb some of that. So you have to be conscious of it. But yeah, there's a lot of things that you can do to regulate insulin kinetics beyond exercise. There's this site you put it in. Is it sub-Q or is it intramuscular? Or is there activity you can integrate to actually push it in even quicker? And like you could literally do intramuscular and then go exercise, and then it's like the quickest thing you could possibly do. So there's a lot of tools in the toolkits to change the kinetics of insulin. And a lot of these studies that say, hey, this insulin, it peaks at the 1 hour mark and it lasts 2 hours, which is what you typically hear when you think of these ultra rapid insulins. That's in a setting, because I worked in a diabetes center where we did these studies, we did these kinetic studies. That's when people are sitting down doing nothing, and they get these really controlled settings, and that's what that curve looks like in those really controlled settings. That's not actually what's happening in real life for 90%, well, for the most of the time when you have normal daily life. You're not just sitting, well, I guess if you're working at a computer, it is. But let's say you have any level of change in your life where you're not sitting down in a chair all day long, it's going to change some of those variables. And so that's why type 1 diabetes, amongst many factors, there's a lot of factors that affect glycemic control and regulating it. Hence why it's so hard, especially right out the gate when you're trying to manage this. There's like 40 different factors that change these things that regulate insulin, not only in the short term, its absorption and how fastly it'll get through the body, but also to its sensitivity over time, to the influx of glucose and to the absorption of glucose into various tissues. So there's all these variables. And in type 1 diabetes, if many people in the audience here live with it, they'll appreciate just how complex that is, and why it often feels like it's a never-ending roller coaster. And that's a lot of why I was so passionate about studying these strategies that I think allow people to get off that roller coaster and live more of their time, not exclusively in their time, but more of their time in this range that it's in normal, frankly. And because I was a big believer, and this is the last thing I'll tangent on here to that question. I was a big believer that when I was diagnosed, that I was told, hey, look, these things can happen to you with this disease over time if you don't manage it. And usually they focus on like, oh, if you don't take care of it at all, like you could have, a limb issue or amputation or lose sensitivity. I didn't come to find out till later when I was researching it that there's a whole host of things that can go wrong with poor glycemic control. And I refused to accept that. And I also feel that patients should never, ever feel they have to accept just the standard expectation of outcomes with any disease. They should, I believe that people should feel empowered to try to improve their outcomes. And it does often take a lot of personal effort along that path, maybe not overwhelming your life and totally overhauling it, but taking one step, one day at a time. And so there's that. I'll try to answer quicker questions than that, but I feel like that's an important thing to state.
No, it's so useful. I mean, I know I have 3 more questions on that, but I'll touch the rest of the questions and come back, because I wish I had met you before I wrote this book on diabetes, because the type 1 chapter now feels very incomplete with so many things that you just touched on. So maybe I have to do some more work on that with you in the future. Okay, so that was the question on preventing a hypo, and amazing how you talked about insulin kinetics based on site, intramuscular versus, in fat, whether it's on the upper body or the abdomen or the lower body, and how you can prevent hypos or quickly manage them with Smarties. So I know in India we have hypo tabs, which are difficult to find in the chemist, but the Smarties candies, we might have something equivalent to that, which I guess we need to visit the candy store and look in the candy section. And I think we might find something similar. So I'm going to
If
talk
you
to.
have labeling in
Uh-huh.
India, if you just look for pure dextrose on the back of a label, it just says dextrose or whatever that equivalent is there.
Yep.
That's all you're looking for. It could be, there's a whole host of candies that feel that way, but it's typically a kind of a chalky-ish
Yeah.
hardened candy.
Yes, that's such a good idea. I'm going to look for those. Okay, so the other question was eating a keto snack, so to prevent a hypo. How about that?
So there's a lot to unpack on that one, but I guess the quick is if you're coming down like this and you eat a keto snack and it just has, if it's just fat, all fat one is going to take longer to absorb out of the gut. Fat can actually be used as a tool to regulate blood sugar levels if you know how you're using it, but it's not something that would instantly bring it back up. Um, so so let me explain different scenarios that immediately come to the front of my brain about this, which is, let's say you're coming down. If you have a keto snack, but you know that the curve is going to be such that you're going to be down within 30 minutes or 20 minutes, a keto snack, if it is truly a keto snack and actually doesn't increase blood sugar levels,
Mhm.
which that would be a keto snack, then it shouldn't actually be quick enough or have any impact on blood sugar to prevent that hypo. So you would have to do something with glucose to correct for that if it's going to continue. However, when the question came up about exercise, this is actually something I was going to bring up as a little bit of a tangent. I've actually used fat as a tool to prevent hypos prior to exercise. So if you have enough fat in your system, I'm not saying go gorge a bunch of like heavy cream or anything, or like any type of oil or anything like that, but fat can also attenuate the impact of insulin on board. So for example, if I were to wake up in the morning and I have a little bit of heavy cream or whatever you might include, if you have coffee or tea or whatever it might be, um, that can actually help reduce the impact of the insulin on board, at least for the period of time that that fat is readily in circulation. At least the fatty acid levels are high enough. And there have been plenty of studies on this where they IV infuse fatty acids and it lowers the sensitivity to insulin. So a lot of people think, oh no, I don't want to lower my insulin sensitivity. But in reality, the primary outcome that we care about with living with type 1 diabetes is glycemic control. It is the number one predictor of how we feel in the moment. It is the number one risk factor for heart disease, for eye disease, kidney disease, nerve damage, and how you feel in the moment and how you feel every single day. And so if you got to focus on that, in my opinion, that's the most important thing to focus on. That's the foundation of everything. And then everything else you can work on top of that. So with that in mind, I don't focus on this insulin sensitivity, insulin resistance within a short period of time. I use it as a tool. So if you were to eat a keto snack, sometimes I find that reduces the flux in glucose and insulin induced glucose drop during exercise. So it's actually a tool I've utilized prior to exercise, especially at times of day where I tend to be more insulin sensitive, or I know I'm more prone to a drop. Including fat beforehand, actually, while it does have calories and you have to account for that, it also does a pretty good job of actually blunting how impactful that insulin can be. And no one thinks about this because including fat as an extra calorie just seems ridiculous to people. But it is something you can utilize if you're like, I'm going to have this keto snack anyways, and you're thinking, you're concerned about dropping. I have utilized those prior to exercise before to prevent a drop. And I've also used things like protein. I've actually found that protein is one of the most successful ways to counterbalance, especially long duration exercise, where I find that with high intense exercise, about 30 minutes in, I start seeing that. And unless I have fat on board, or I include something like protein, because what happens is when I start seeing this 30 minutes in, if I have protein, the drop in glucose, let's say, here's the analogy. So glucose at 30 minutes in, it's going stable, and then starts to drop. Well, protein has a slow influx in glucose. So what's ending up happening is they're offsetting each other, right? So the glucose into the system from protein is slow, and the glucose drop from exercise, from prolonged exercise, can often be slow. Well, unless you're talking about absorption, then absorption is fast. Okay, so but either way, it's a way to completely one for one mirror the glucose lowering effect with the glucose elevating effect, and I find that keeps me flat as an arrow. Oftentimes going into exercise. So either way, there's different tools and strategies that people can leverage, and there's many others, by the way. These are just the nutritional ones where you're talking exclusively about like a fat-based food or a protein-based food or a carb-based food. But around exercise, they all can be leveraged in different ways. But as a safety concern, when you are going low, obviously it's pretty important to correct that and prevent an hypo, because hypos are nothing that any of us want to really experience. They feel terrible. They affect how you feel, often not just in the moment, but for the rest of the day. And so mitigating that is really important. But I find that if I overcorrect, it causes more problems. So I try to be very judicious and careful with that.
Okay, so your workouts are, oh yeah, I know. I have to ask you this about what you just shared about using the keto snack, either a protein snack or a fat-based snack, and that keeps you steady. Would you say, Andrew, that that probably works better for somebody who is keto adapted or who is already in nutritional ketosis versus the same exact snack being given to someone who is eating 80 plus grams of carbs a day? Will it still help them?
So this almost gets to an individualized
Yeah.
day by day type
Yes.
of thing.
Yes.
So the principles that I said when it comes to carbohydrates, they're the fastest to go in the system. They raise you quickly. Protein goes slow and over time. Fat is kind of this subtle. It doesn't really have much of an effect on glucose, but it can lower the impact of insulin quicker than it does actually affect glucose levels. And so those principles still apply. But when you think about different dietary strategies, one, everyone has to make their own individualized choice on what works best for them, their environment, their culture, how they feel, how it manages their disease. That said, what I have found is that it really depends on the moment. So if I were to wake up in the morning fasted prior to exercise, I find that without food, regardless of what diet you're on, without food, it, there's so many ways to answer this
I
question. It's not well, what's the most applicable thing to be actionable on for people.
People who are in nutritional ketosis, how does that fat or protein help them versus, again, this is not for any individual here on this,
Gotcha. Yep.
not
Yep.
versus someone who's eating more than 80 to 100 grams of carb a day. will a fat or protein snack prevent hypo for them the way it would for a keto adapted or fat adapted person?
Everything I said should apply in both settings. The
Okay.
difference is that when you are thinking about any of these dietary strategies, well, oftentimes when you think about exercise, you really have to think about here's your exercise in the screen if you guys see me, this window. And you have to think, what did I do over the last 4 hours or the earlier part of the day that will impact this window? And so a lot of times, depending on the diet, if you said I had 40 grams, if you have 80 grams or more of carbohydrates in your diet, let's say you do that and you had a meal beforehand within 2 to 3 hours, the insulin you injected to manage that is still going to be on board. And so you have to think about during that window of time, what's the insulin on board? Because that is what is going to be affected by your exercise mostly, because insulin on board, it's how quickly it's going to be absorbed, also how quickly it is going to circulate through the body. And so if you had 2 units to 3 units here, it doesn't seem like that big of a shift. But if you take 2 units, shift it over here, and you put it up to 3 units, that delta, that difference is huge, right? So you just have to consider what you did leading into the exercise and what is acutely happening. And so when someone is consuming more carbohydrates, typically they're giving more insulin at the meal. And as a result, they have to account for how is that extra insulin, especially the rapid acting insulins, going to affect them leading into exercise. That does lead people a little more prone to flux up and down. What I have found when I switched to a ketogenic diet, and this has not been studied, by the way, just in full transparency, this has never been studied in type 1 diabetes under an exercise setting. I'm only giving my personal experience. It should be studied for
Yes,
sure.
for sure.
Is when I switched over to a ketogenic diet and I was doing injections. So I wasn't using a pump that gave the same type of insulin all day. I was using something called regular insulin. Regular insulin, I don't know what it's called there, but it's like Novolin R, Humulin R, and R insulin.
Act
What I
rapid.
found is that, do
Act
they have
rapid.
that there?
Act rapid. Yeah.
Okay. And so when you take that insulin, it lasts for about 4 to 6 hours. But what I found is that with protein and fat-based meals, it was brilliant at the glucose elevating effect of protein and fat to the glucose lowering effect of that slow insulin. So over time, the goal is to stay here or only slightly off, right? It's never perfect, but staying even keel as much as you can. Now, when I would go into exercise with these longer duration insulins, I found that I was way more stable, almost across the board, even at very, very, very high intense exercise. Now, why would that potentially be? We have studied very, very high end athletes who are running over 50 kilometers per week, less than 10%, 15% body fat, competitive. We've tested triathletes who were highly competitive athletes who were their VO2 maxes were extremely high. Their cardiorespiratory fitness was through the roof in the top 90 percentile. What we find is that when we put them on a high carb diet and then switch them over to a low carb diet, around the 4 week mark, they perform identically no matter what diet they're on. So they don't have diabetes, by the way. These are just non-type 1 athletes. They perform exactly the same regardless of what diet you're on. But what we found is that the amount of fat being utilized versus the amount of carbohydrates being utilized during the exercise flips dramatically, right? So the need for glucose is higher on high carbohydrate based approaches. Once someone adapts to these low carbohydrate based approaches, the amount of carbs being utilized during exercise not only comes down, or glucose oxidation in the body goes down, but the amount of fat goes up. So I've always felt that my personal experience with finding more stability during exercise was a reflection of my potential, although it hasn't been studied in type 1, but it has been studied outside of type 1, that it's a potential flip in the amount of glucose going down, or the glucose needs going down during exercise, and relying on a fuel substrate that your body can readily metabolize. In type 1 diabetes, you have all the machinery still intact to metabolize fat. you don't have the ability to metabolize carbohydrates and glucose the same way. So you have to give insulin manually to do that. We've lost that internal control. But if you think about the idea of flipping the needs of energy from glucose to fat during exercise, you're reducing the amount you need of a fuel substrate that you have to manually utilize insulin and various external tools to regulate. So the different way of saying this is you're increasing you're shifting away from a fuel substrate that you have to manually do all these tools and tricks to try to regulate, and it will never be like endogenous metabolism is. And you're increasing the amount your body is utilizing a substrate that it automatically can do. It automatically metabolizes. It automatically knows how to utilize that. So you're shrinking this less predictable, less manageable aspect of the disease and increasing the one that your body already knows how to regulate on its own. If that's a way of putting it, I don't know if that was helpful. If not, I can state it differently, but that's also worth considering when it comes to actual exercise glycemic stability. And that's a big issue, by the way. It's one of the big unsolved problems in type 1 diabetes is how do I get normal glycemic control during exercise? And I'm a big believer that nutrition plays a huge role in that because it shifts glucose and fat-based metabolism almost completely up on top of itself. It flips it over. But you're also reducing a lot of the inputs into the system that lead to a lot of unpredictability. Right. The more glucose into the system, the more insulin in the system. These two factors are the biggest predictors of flux, the change. And so the less you put into that, the less of the flux you may see. And so either way, it's just a tool. It doesn't have to be utilized. Each person can do it in their own way, but it's just something that makes life so much more predictably, especially around exercise, because there has been nothing to crack the code of exercise in just flattening it. And the reason that is because the insulins that we take, the fastest form of insulin that we have right now, even if you intramuscular inject it, is at least 3 to 4 times slower than endogenous glucose requirements are for carbohydrates. And as a result, it's almost impossible to always reliably match these things. And that's where you constantly see these roller coasters is this constant attempt to kind of catch the wave after the wave is already happening. And that's why it's hard. It's not that people don't know what they're doing. It's not that people with type 1 are mismanaging by any means. It's the fact that the tools we have right now aren't fast enough to match the requirements of certain foods that we eat, how fast it goes into our system. It's just it's a mismatch. And it's not our fault. That's just a lack of frank innovation and pharmaceutical availability for having faster forms of insulin. Although I will caveat that and say, if you had insulin so fast that it actually matched carbohydrates, they would be extremely dangerous, more dangerous than they are now. So just be aware if we ever get to that point.
My gosh. Wow. Yes, that was very helpful. And I like how you said, that being fat adapted gives you this predictability where, and I've never seen such straight lines. And I know it keeps you, stable. Your day goes better. You're satisfied. You're not worried about it's going to be dangerous. The workout goes the way you want it to. The rest of the day goes the way you want it to. And yet it's everybody's individual choice, whether they decide to become fat adapted. It makes life more predictable, but everybody gets to decide what they want to do with their carb intake and fat, being a sugar burning machine or a carb burning or fat burning machine. People are also experiencing the glucose going high during workouts and post workouts. What's that about?
Yeah, so that there's a number of variables that may play into it, but the most predictable of them is the intensity of exercise. So if someone has a lot of glycogen stored up in the liver and they increase their exercise intensity high enough, your body will release stress hormones. It's not a bad thing. That's normal. That's normal response to very high intense exercise. Those stress hormones actually can go to the liver and actually break down the glucose that's stored there and instantly release it into circulation. Your body built that system up so that you could actually mobilize fuel during exercise if you were under extreme stress or instantly needed fuel substrate. Obviously, we live in a society now where we're not, uh, we now live in an environment where those evolutionary tools have a little bit less relevance to the need to run away from a dinosaur or something, right? But that's why it happens. Is a lot like if you ever gone up and done something extremely stressful with type 1 diabetes, and all of a sudden, like you know, your heart rate goes up and you feel very anxious, and you start seeing your blood sugar rise due to stress. Some people experience this with stimulants like coffee or caffeine or tea. If they have too much of it, it can increase them as well, because all this is all of it underlying it is a stress response. And in the context of exercise, that's a good thing. That stress response is a good thing. But it is also causing the liver to mobilize glycogen. So it really comes down to the intensity of exercise. We don't always see this at lower intensity exercises, but it's all relative to the person. So if they do a very high intense exercise or something that really increases their heart rate rapidly, you can see these type of changes pretty predictably, but it's almost all based on the intensity level of the exercise. The opposite happens if you were to lower the intensity even a little bit and do that exercise over a longer period of time. You'll find that you may stay stable for a short bit, but then you'll start dropping. And that could be not just due to some of the things we spoke about on insulin absorption or insulin sensitivity. There's actually a well-known effect of something called insulin independent glucose uptake. And your body actually starts to send glucose receptors from the muscle up to the edge of the cell of the muscle, independent of insulin needs, and starts shuttling glucose in over time. But usually that effect is like 2 hours post the initiation of a long duration exercise. It doesn't happen instantly. So these quicker changes that you see in glucose and exercise, especially within the first 30 minutes, all that is absorption. Almost all that is almost predictably absorption effects of around insulin, increasing heart rate, increasing capillary like blood flow to the area. Whereas post 30 minutes to around 2 hours, that can be a reflection of other factors, not only the absorption but also sensitivity factors. And then 2 hours and beyond can be sensitivity and or what they say, glucose uptake independent of insulin. So there's all these different layers at different steps along the process, but it's all contingent on the intensity of exercise, the duration of exercise. So there's all these different things that go into it. One thing that I also want to state here, because you mentioned this earlier, is the reason I have only recently started doing this. I never really had much of a social media presence. I only did that because I found that a lot of parents with kids with type 1 said, I can't exercise and have normal glycemic control, or I can't build muscle, or I can't do X, Y, and Z. And so the only reason I even post those graphs on, like, say, Instagram or whatnot, is because I want people to know that, one, it's possible. Yeah, it's absolutely 100% possible to show up 90+% of the time and get there. But I also want to state, I never started here. I never started at this place where I just woke up and everything was flat. You know, like, it took me a lot of time over the years to learn the different tools and strategies. I also had the help of science to help understand why some of these things were happening. But the biggest thing that taught me was just experience. When you do something and it works, you learn something great and you can apply it. But if it doesn't work, try something else. You know, and ultimately, I've done that over the years to the point where what I do right now isn't necessarily what I would recommend for anyone else on this audience, right? Like, what I'm doing for myself works for me. There are some general principles that can apply, but you ultimately have to make it work for you. And that's a critical part of type 1 diabetes that's often underappreciated, is that each person truly is their own individual. We can start with the core principles, but you ultimately need to understand that you have to tailor it for what works for you. And you can look at a bar graph on a publication. You know, a scientific journal says that if you eat this low carbohydrate diet, that you're going to get X blood sugar control. But the reality is that that line may be a reflection of 10 different people in that study. And what if one of those people didn't respond the same way? And what if that one person is you? So you ultimately use science, use tools, you know, anything I'm saying, and say, oh, that might be a good tool or strategy. But if it doesn't work for you, don't ignore that. It doesn't mean that what that science said is wrong. It just means that maybe you're a little bit different. Maybe you're a little unique. and you need to trust your own experience. There's nothing more important than trusting your own experience, especially if you try something like, well, they told me this thing would work and it never worked for me. Well, there might be a reason for that. Maybe you might be doing it wrong, but if you're not doing it wrong, maybe it just doesn't work for you and you have to do something else that works for you. So I think that's important to state.
Absolutely. Nothing replaces experience. And yes, having good science, having good guidance, maybe a checklist to go through. Did I do this wrong, or do I need to change this, tweak this, some process, some
Yeah.
scientific process, right? It gets stressful, but hopefully with the right help and the right support, you can figure out the answers. So
Yeah.
yeah, thank you. I mean, amazing. I'm going to let people ask their questions now. Shweta has a question.
Yeah.
Do you have time, Andrew, to take some questions? Are you okay?
Yeah, let's go. I will keep going. Yep.
Okay, thank you.
Yes, thank you, Dr. Roshni. Dr. Andrew, big fan, really, and really those graphs that you post on Instagram is just like, yes, I'll get there someday. So thank you.
You will get there. You will get there.
Really kind. So my question was about, blood sugar levels rising during exercise. You've mentioned like long duration of exercise. So how do you define that?
Yep.
You did mention 2 hours plus. So is that, and also the intensity and the heart rate intensity? If you could just explain that a little, that would be helpful.
Yeah. So when we talk about intensity level, it's really going to be up to the individual and relatively speaking, but it's always how we define intensity in exercise physiology research or science is relative to someone's maximal. So I can't say a heart rate of 100 or 120. That depends on your maximal heart rate. So it's all relative to a level of maximal intensity. The one way that you can apply that maybe is a little more applicable to each person is saying, let's say that you were exercising and you're able to have a full conversation. That's low intensity. Let's say you're able to have you increase the intensity more and you're able to have a little bit of a conversation, to say a word here or there, but you're not able to sustain not this type of conversation, right? That is, you could say that maybe like it's getting into the moderate intensity area. When you start getting to the point where you can't hold a conversation, that starts getting into the high intensity arena, where you can't and we've all been there if you've ever given intense effort in any type of exercise where you just can't. If someone were having a conversation, you're like, not right now. So that is when you start getting into the very high intensity level. Now, there's another layer above that where that's maximal effort, to where you are going, you're giving everything you have to give. And a lot of people actually haven't really experienced that to the point where they really gave everything. That end of the maximal it guarantees a blood sugar elevation. I mean, it guarantees it. If you actually give maximal effort for any period of time, blood sugar is going to go up because that's a stress response. I've actually ran for an hour and a half before, started to see my blood sugar drop. I was out of Smarties. I was about 30 minutes from home. And I knew that if I would start sprinting after an hour and a half, I was exhausted. I knew if I started sprinting, I'm not recommending this for anyone. This is dangerous, by the way. Always carry sugar tablets with you. But I'm just giving you a personal example. I was exercising for a super long duration of time and my blood sugar started to drop. I ran out of sugar tablets. And so I was like, the only thing I have left, and I'm pretty far from home, is I started literally max sprinting an hour and a half in, literally absolutely to pure exhaustion. I had nothing, I could barely breathe. Blood sugar came up 40 points. And that was after an hour and a half to exercise. So that's usually a pretty reliable thing that happens with max intense exercise. But to give better definitions to your direct question, duration of exercise, it's all relevant. Okay, it's all relative. So 30 minutes versus an hour versus 2 hours. When you talk about long duration exercise, most people are thinking somewhere at the 45 hour long mark or longer. That's when they're starting to think that's a very long duration form of exercise. But when they typically think of it, they're thinking of something that's sustaining an elevated heart rate over that period. That doesn't mean, so you're on a cycle bike for an hour plus, or you're running for an hour plus, or you're doing some type of aerobic exercise for that period of time. That can also be the case if you're lifting weights. only if the rest period in between each set is short enough to where your heart rate stays elevated. Because what I have found, and what seems pretty true, is that the one metric I focus on internally is my heart rate. So not that I'm actually not measuring it. I'm actually being subjective. Like, okay, I know if I get to this level and I feel it, I can actually predict when I will go high. I can also predict if I stay at this heart rate for long enough, I'm going to drop within 30 minutes or an hour, depending on what I just ate. So I use my internal heart rate as a guide, but my internal heart rate is personal and direct to me. So what I recommend that each person does is start to use experience in the gym or wherever you exercise, if you're running outside or whatever you do, if you don't go to the gym, use your internal heart rate as a relevant marker for yourself. And if you increase it high enough, and you know that if you keep it there for 30 minutes or so, you're going to start dropping, know that, okay, if I'm at that level, then I'll see a drop. If I'm lower than that, then I probably won't see a drop. So you have to keep your own internal gauge, honestly, because you could wear a heart rate strap. I've done that before. We've done research where we do all sorts of advanced measurements, but I don't wear all that stuff when I go and exercise. I just want to go enjoy exercise and experience the almost meditative experience of being in a really focused exercise session. I think it changes the whole day for the better. So I just use a little bit of my own internal guide and flag post for that. But I personally have found that once I start creeping beyond 30 minutes, that the insulin absorption starts to really kick up, usually due to a heart rate effect over time, which is a signal that your body is going through a number of changes. It's increasing blood flow to peripheral tissues, such as the muscle where the insulin is being absorbed from, fat tissue as well. And so that's just a surrogate marker or a sign that all these other physiologic changes are happening, which will change how fast the insulin gets in. So it's not per se that any one of these numbers or specific things are exactly what's inducing the metabolic effect of exercise. These are just signals that we can actually use to give indications during an exercise of how long you might be able to go before you might drop. And that's going to be very individualized to each person. For me, 30 minutes into if I get on these Rogue Echo bikes where you're like pushing feet and arms, it's a whole body type of aerobic kind of heart rate training exercise. If I go over 30 minutes on that and I really go for it, I know exactly what happens in 30 minutes. If I don't have food. Now, if I were to add fat beforehand or I add protein, I don't typically have that same issue. I might be able to get to about 60 minutes before I start seeing an effect of dropping. So the pre-exercise nutrition, the insulin you have on board leading into it, the duration of exercise, and ultimately the intensity of that exercise for that duration ultimately is what's going to dictate whether you're going to have a blood sugar drop. Usually you're not going to have an elevation in glucose unless you're really pushing the intensity pretty high. And if you don't like that, then you can work on regulating your heart rate a little bit as a measure to bring that down. So if I were to go do max sprints, which I sometimes do on these aerobic exercise tools, or if I were to go running is one of the best ways for me to spike my blood sugar level. I find that I have less of an effect in other domains, but running just does it for me almost always. It's just, I know I'm not giving you a direct answer of like, oh, well, 2 hours is long duration versus this. In science, we would say over 60 minutes is when people start considering long duration exercise. If you start pushing beyond 70% of your max, whatever your max measure is, heart rate, VO2 max, whatever it is, then you're starting to get into the higher end of sustained exercise above the kind of moderate range. But all these things kind of aren't really relevant to the lived experience of a person who's out there exercising and doesn't have a VO2 max on their face or aren't necessarily monitoring their heart rate with a strap. A lot of the wearables people use can give you an idea of heart rate, but they tend to be a little bit less accurate during exercise. So they aren't always the best way either. So I always think internally. And one way that I always like to teach that I have found that works extremely well is if you've ever got up to do a public speech or you're doing something extremely stressful, you can feel this like almost like burst of stress, like for me, my face gets tingly and I feel very anxious. if I do exercise intensity hard enough, it's a very similar feeling. And so I know the second I cross that threshold, what's going to happen to my blood sugar level. So you can use a lot of these other things that you've experienced if you're mindful of your body, if you're aware of your physiology, and it can help predict some of the other exercise related responses. But ultimately, using your lived experience and how you have responded historically is your best flag post for how you will deviate out of that, if that makes sense. So use your foundation, and then when you start inducing change or feel something that deviates from that, think about your heart rate, think about how long it was, and think about what you started with from your insulin and glucose levels, and all that can start to accumulate information that you can start building more predictable outcomes around exercise. Hopefully that's helpful. It's very nuanced.
Yes.
In type 1 diabetes, a lot of people never appreciate just how complicated and complex this disease is until you live with it. So I'm trying to give a round enough answer for applicable tools. Was that helpful?
Yes, very much so. Thank you. In fact, all these different indicators that you said really resonated. It's stuff that, I think intuitively we all do experience, but it's really good to hear from, someone else as well. So thank you, Dr.
Yes. Andrew, I think what you've done is you've given everybody various different mileposts or key signs to look for in their own exercise now when they go forward, when they see fluctuations, because I don't think I could have ever been able to walk them through these things the way you just have, because of your lived experience. So it's extremely useful to have you do this with us today. Rohan from Blue Circle is here. And
Hi, Dr.
hi, Rohan. Hi. Do you want to ask your question?
Yes. Hi, Andrew. Thank you so much for taking the time out today, and Dr. Roshni for organizing this. My question is regarding bolusing for this diet, right? Low carb, high protein, moderate fat diet. And like you mentioned, I was using regular insulin with pens, and it used to work perfectly. And I'm struggling with the pump because in pump, if you use regular insulin, right, it will stack on and you will get into an hypo. So I'm using rapid insulin, but now I have to take 2 shots, and it's not as I'm not as good at it as I was on a regular insulin, right? Because sometimes I take it after 1.5 hours, sometimes I take it after 1 hour. It's not matching the peak, right? So any advice for pump users on how to bolus for this sort of a diet? Thank you.
Yeah. So Rohan, thank you for the question. So there's different strategies that people use when they use a pump, but everything you're describing is a very real lived experience with a pump. What I have reliably found that because it's rapid acting insulin, right? So rapid acting insulin is much more apt to have quick changes with more potent peaks because of the shorter duration of it, right? So if it changes, it shrinks it and it goes much higher. Whereas regular insulin's so out here that if you were to shrink it, you're not going to shrink it that much. So your peaks you only get a little bit of a bump compared to with rapid. I mean, you could bump it up 50% potency, depending on what you're doing. And so, yeah, that's not uncommon. But what people often do with pumps, and I've done this before, is something called a dual wave bolus if your pump allows for it. So one of the generic rules people have done, which is not always applicable, is a 50-50 split. So a 50% up front and then 50% prolonged over, let's say, 3 to 4 hour period, which tends to somewhat match the kinetics. So I don't actually have a pen. I wish I could draw here, but what that's doing is it's giving you the initial bolus like this, and it's also giving another bolus that's sitting like here. The stacked response of both of these together, where you have this plus this together, is going to be more like that, which is a lot how regular insulin works. Regular insulin comes up like this and kind of stabilizes. But obviously, you can play around with that in each individual person and setting. But ultimately, if the peak too early is dropping you early, then you know that your 50% should be like 20, 30%, 40%. It shouldn't be 50. Or if you start going high too early, then you know that your initial should be higher, and you can as you can play around with it. But people typically do a 50-50 split and have some degree of it, especially with the protein and the fat on board, that prolongs over the next 3 to 4 hours. And keep in mind, why 3 to 4 hours? Well, because if you give insulin at the 3-hour mark or at the 4-hour mark, it's still going to last for another 2 hours, hence giving it the full 6-hour effect of a protein. And then you also have that initial response. So when you first eat the food, even if it's protein based and you maybe have some fibrous carbohydrates with that, you're still going to have an initial peak with that food. I'm sure everyone's experienced that, right? When you, even if it's low carb, you eat food, it doesn't necessarily always go like this. Sometimes it kind of creeps up quickly and then starts stabilizing over. A lot of that is due to some of the, like when protein is consumed, a lot of people think, how is that increasing my blood sugar? It's protein, it's not glucose. What that proteins, amino acids actually go to trigger something called glucagon. And glucagon actually then causes you to have a release of glucose from the liver. But then you also have gluconeogenic amino acids that can be converted into glucose over time. So in essence, 50-50 splits, a typical way that people do it, but your lived experience is a real one in that it's a little more unpredictable around activity and change. If you're sitting down, like I'm sitting down right now, like not moving, I'm just sitting here, right? That's going to be pretty predictable on what happens. But if I start, I'm like, oh no, I have to go outside, or I need to go pick up my son from school, I need to walk to the store. All that with rapid acting insulin is a little less predictable. There is one exception to that, Rohan, is when you're using these automatic insulin delivery systems. I recently started playing around with that, and I find that you have to know different tools in the toolkit when you have that, because they provide a lot of, they give you a lot of relief in thinking about the disease all the time, but they are not perfect at all. You have to know what the limitations are. The same limitation, Rohan, when you have a pump and how rapid it's absorbed is the same limitation AID technology has. It's also why the hardest thing to control right now with AID technology, automatic insulin delivery, by the way, or hybrid closed loop, where it automatically administers insulin based on CGM responses, is exercise. It doesn't match. I go into extensive detail about, it doesn't fix diet. Okay. It doesn't fix the diet. It actually, the hardest things is exercise with these tools, because you have the rapid acting insulin on board, which is a problem any pump user has, period. So yes, it changes the difficulties around, Rohan, right? So like now you have something attached to your body. You don't have to maybe carry around insulin all the time. So that's a huge win for people. So you got that win there. But now you have to start thinking, okay, well, what do I have to change in these other aspects to make up for what a shot gave me, which is maybe a little more predictability, less of the rapid nature of insulin. And so it's always a give and a take. Nothing is perfect, including these next generation technologies that I've started playing around with a little bit. They're not perfect either.
Yes, just to add to that, I am on a Riley link with a old pump. So I'm using DIY looping, but exactly, like I am only using it for the night, because in the morning when I'm exercising and going about, it's not doing the task that I want it to do. So you are right.
So let me touch on that real quick. So what I actually do, because I'm not using a Riley link, I'm using OpenAPS, and I have preset settings. So, but it's all about what happens to you on your personal settings. So let's say I pull up, so I don't know if it's going to blur it. Oh, there you go. See that? I don't know, it's a little blurred. I can take the blur off. So if you see this little bar up here for me, just like with other tools, they have these preset settings. And what I actually have is when I go into the profile, I have a number of different settings that I have preset. And what I know is, like, for example, if I'm going to do a very long duration exercise bout, I have settings that I will set maybe even before I start exercising, like 30 to 45 minutes before, or during the entire exercise bout. So let's say I'm about to exercise for to the prior question, I'm going to exercise for 2 hours. It's going to be super intense. It's going to be outside. I might have heat as well. I know, and I'm fasted. Let's say I woke up, I'm just about to go fasted. What I'm going to do is 30 minutes before that exercise, say I'm a flat line, 30 minutes before that exercise, I'm going to set it to reduce my insulin requirements 50% out the gate. And then I'm going to ride that in. But I know that there's going to be a point where I need to set that setting to 0% insulin. So basically suspend it within that exercise. Because ultimately what someone else Why other people won't get hypoglycemia until like an hour and a half, 2 hours, because we've studied that too. We've actually pushed people to get to hypoglycemia without type 1 diabetes during exercise. It does happen, but usually due to the inability for the body to maintain prevent hypoglycemia forever. It does get to a point where they can't. But in type 1 diabetes, here's where you have an advantage. You have total control over your insulin. You have total control. Whereas in normal physiology, there's limitations. And so you actually have total manipulative control over how much insulin is on board. But here's what you have to do. You have to think predictably ahead of time, make a decision beforehand on what's going to happen later, because our insulin's so much slower than people who don't have type 1. And as a result, you need to make decisions ahead of time. So let's say 30 minutes out, you need to start lowering your insulin quantity. So you reduce the total insulin on board. Or during exercise, especially for me, long duration, there have been times where I've completely suspended insulin after making a pre-setting to reduce my insulin 50%, even 40 minutes before exercise. And I've gone to 0 for over an hour before. So if you think a little bit ahead of time and you have some pre-settings where you can reduce the potency or the amount of insulin being administered, it takes a little bit of more cognitive work, but that's the limitations of AID, is that it will never be able to make up for the rapid flux during exercise. Exercise will change insulin absorption on a dime, but these technologies can't account for that unless you sit in hyperglycemia. That's what a lot of the current AID technology and hybrid closed loop does. It will never allow, a lot of these technologies over the market don't allow people to go below 120, some 110. And the reason for that is exactly what you stated, is if you were to live in normal glycemia, have exercise, boom, it's over, okay? And so what they do is they force people to live up higher so that if they do start crashing, they have a buffer of not only that lower end threshold of 120, but gives them another 40 milligrams per deciliter, 50 down to 70. At the top end of normal to the threshold of hypoglycemia, that window is actually a buffer system for these hybrid closed loop technology systems, because they won't let you to get lower than the top end of normal, so that if you do come crashing down, you have this buffer to account for it. But you, Rohan, can think ahead of time. Well, I want to get real tight control, and I want to be able to have a normal exercise bout without going low or just gorging carbohydrates during exercise. You just have to think ahead of time and think, how do I lower my insulin quantity far enough out, lower it enough, far enough out to prevent that crash during exercise. So again, you can eat food, you can lower insulin, you can do a combination of both, or you can just change the type of exercise you're doing. There are all these different things you can do. But I personally like to just lower the insulin, because if I'm exercising, I don't want to feel like, hey, I just exercised and had to consume 60 grams of carbohydrates to correct a hypoglycemia. I feel like I just wasted the exercise, So for me, I just like lowering insulin, because that's what people without type 1 diabetes, you're earning that lower insulin. That insulin's an anabolic hormone. It stores fat and also, helps store other tissues. And so I feel like I'm earning the deficit, that I can, that's where the calories to make up for exercise, if you want to stay normal body weight, or that's where, you can help lower weight. That's a difficulty in weight management too in type 1 diabetes, is a lot of people are never actually lowering their insulin. They're kind of constantly manipulating it around with food. And so when they exercise, they need more carbs because they're dropping. And so they washed out the caloric deficit of an exercise that exercise would do for them by just over consuming. So it makes weight management a little harder. But if you know these different strategies and why people are losing weight when they, if you increase exercise and then, well, I won't go on a tangent. I'll just say the quick answer is all these different factors play into it. I like to lower insulin beforehand.
Amazing. Rohan, did that answer that for you?
Yes, thank you so much.
Yeah, thank you. And Andrew, in my poll today, 7 out of 9 feel like they have insulin resistance. So needing more insulin, gaining weight around the belly, fatty liver, high triglycerides. So
Okay.
Yeah, so I think they will feel a different experience of this than someone who's actually in close to normal levels of insulin sensitivity.
So let's touch on that then. So in type 1 diabetes, this is the bad news, but there is good news. The bad news is that because of the way you administer insulin, with these tools in the periphery, a normal individual, let's say my liver's right here, right? Okay, well, normally when insulin's released into the liver, it goes direct to the liver. So someone without type 1 diabetes, okay, so when it senses blood sugar elevation, it releases pre-stored insulin direct into what they call the liver hepatic circulation, which means it's basically going straight to the liver. The liver will basically eat up a ton of that insulin, and then a lot less of it gets to the periphery. Well, in type 2 diabetes, what happens is there's a resistance, an overabundance of nutrients to where this liver's already, this is a simple way of putting it, but in essence, you have an abundance of these nutrients, or you have resistance. And as a result, a lot of it is making it to the periphery as well. So not only you already taking what is needed for the liver, but now you're having a lot more in the periphery. Well, that excess insulin in the periphery can facilitate insulin resistance. It's in part why people with type 2 start developing insulin resistance on top of the excess body weight and adipose tissue and the excess in lipids that are in circulation. In type 1 diabetes, it's become more common now because of people with type 1 are now experiencing the same metabolic health issues like obesity and overweight that the general population are. But traditionally speaking, people with type 1 were underweight, not even normal weight, but underweight. But because of the route of administration of insulin in the periphery, you're also hypersaturating the peripheral tissues with insulin. And this can lead to something called iatrogenic hyperinsulinemia, which actually mirrors the elevated levels of insulin in the periphery, which can cause peripheral insulin resistance. There's nothing we can do about that. I mean, we can't change the fact that we have to administer insulin, period. And the way we can do it is in the peripheral tissues. There's no route around that right now, except for there is inhaled insulin, but that has limitations. There are trying to develop ways to administer it into the hepatic portal vein, but this is all experimental. The inhaled insulin is not experimental. It's on the market. I don't know if it's available in India yet. It's from Afrezza, Mankind. But either way, they're not the ones that most people are utilizing. So everyone with type 1 and is supposedly, according to the scientific evidence, has some degree of insulin resistance relative to someone who wouldn't have to administer insulin in the periphery. Mm-hmm. But what can you do about that? It is a dose-dependent thing. So the more insulin you have in the periphery, the more you would facilitate, by all logical means, more resistance. So what can you do to lower your insulin quantity? That's things like, getting your body weight into a normal range. Exercising increases insulin sensitivity, sometimes not just acutely post-exercise, but sometimes for 24 to 48 hours post. In fact, we know this in type 2 diabetes research, actually from a friend of mine who's done this research in type 2. You see about 24 hours or 48 hours of insulin sensitizing effect from an exercise bout. And so a robust exercise, like not that 30 minutes of walking isn't robust, but like an effortful, purposeful weightlifting session or an effort for cardio session that can extend for over a day. But you have to keep doing it, right? So that's 48 hours, but then you have to keep doing it again and again. But as you start doing more exercise, yes, it's a short win, and it does go away, but you're now building healthier tissue. So you're building more muscle tissue that then can be more receptive to utilizing that insulin. And so, for example, I'm 230 pounds now, 235 pounds. I'm technically on the high end of overweight, although my body fat percentage is pretty low. So it's like around 10%. But my insulin requirements are that of the average kid with type 1 diabetes on a very low carbohydrate diet. But not just because I'm doing a very low carbohydrate diet. It's because I'm trying to maintain a body weight that it allows me to be very sensitive. I won't say it's like the easiest thing of all time either, especially having dealt with obesity as a kid. I'm always it's always predisposed to having to consider that. I could easily put on weight. There's no problem about that. Getting it off is much harder, but the exercise is huge. So I'm trying to keep low body weight. I try to maintain exercise over time. And you can do dietary strategies like we talked about by lowering carbs, which has reliably been shown in the literature to lower total insulin requirements. And so those are 3 different strategies that we know are evidence-based approaches to lowering insulin. And ultimately in type 1, because you're administering the periphery, the lower the peripheral insulin that's there, the less apt you are to be insulin resistant. So that's important to know, because obviously insulin resistance is kind of this underlying pathology that leads to a whole bunch of other metabolic issues. And so for us with type 1, it's really important that we have access to 24-hour awareness of what our insulin is, right? Most people would kill for that type of information. But what it's giving you is the 2 most important metrics of metabolic health that you could possibly have access to. Glucose, even if you don't have a CGM, if you just have a finger stick, you have way more resolution on your glucose than someone who doesn't have type 1. Now, if you have a CGM, you get about 280 times the resolution in a single day. And over weeks, you're getting tens of thousands of times the awareness of what happens with your glucose. And then you also have the administration of insulin, where if you have an AID technology, you're using a Riley link, you're actually seeing how much insulin is being administered per day. Like in mine here, if I were to go into my system, I can actually pull up how much insulin was I using. Yeah, so it shows. So I don't know if you can see that there. At the top, it's a little blurry. Let's see if I put it in front of my face. There we go. So this is the total insulin right here. And then I can do an assessment like, was I using more or less insulin that day? If you're injecting insulin, you can also look and say, okay, was I using more insulin today versus yesterday? And you can actually quantify the total amount. And there's also tools about like looking at time and range and other things too that give you some awareness of how you're doing over time or day by day. And you can kind of play around with these things. I find this to be fascinating just as a patient with type 1, but also a scientist thinking, I used about 20% more insulin a day. What did I do? Well, I sat on my butt all day. Like I sat on my butt in front of a computer all day instead of walking to my son's school to pick him up that day. We drove to pick him up. These little things that people often don't realize, but if you just pay attention, just notice and actually pay attention, you can really get a lot out of that learned experience of just noticing.
Oh yeah, I'm taking my sedentariness for granted because I don't know what it's doing to my daily insulin requirements, right? I'm not paying attention to this. Like you said, that blip that you saw on a sedentary day versus an active day. I know, Azim, you had your hand up. Did your question get answered or did your hand get tired?
It got tired. Yeah. No, thank you so much, Dr. Rashmi, for doing this, and Andrew, for sharing your wealth of knowledge that you have gained through your experiences. I just have like a quick question in terms of like the mental health, because like I am a kind of person who does a lot of reflection about things that I've done throughout the day, and everything kind of revolves around my blood sugar levels. So if they are like going high, my mental health will get affected, and then I would not do the tasks that I would actually want to do. So there's like a loop or a cycle that keeps on going. And for everyone, like the solution for solving for mental health is different. Like I started doing meditation, started being like very mindful. Just like I'm more curious to know about like how do you manage your mental health, and what are like say some tactics or methods that have worked for you that maybe could work for all of us, because this is like major topic which I feel for type 1 diabetics.
Yeah, so you're going to get nothing but full transparency here, because I feel like this is one of the, especially in America, one of the most under talked about topics. It's stigmatized, yet everyone experiences it. Everyone experiences it, and people with type 1 were a little more prone to have to navigate more of the highs and lows of the disease, because we know that if you just Google hypoglycemia or hyperglycemia, I mean, the symptoms of these, of course, are things that are symptoms of how we feel. Am I irritable? Am I agitated? Am I anxious? I mean, those are all things that affect, our current in the short term mental health status. So one thing that I obviously found is, obviously, as much as I can, I try to stay in this kind of as normal range as I can, and reduce the amount of fluctuations I have, because I've actually found that sometimes it's not even so much if I'm 170 or 180 versus 120. It's like the dive. It just makes me feel horrible. I can feel the high, but it makes me feel anything as much. Obviously, hypoglycemia is like pertinent, but the dive is the worst for me. And so so I just try to eliminate as much as I can that barrier, but you can't completely remove it, right? And so that gets to the next part, is like, what other tools and strategies have I personally applied? Exercise is maybe one of the most powerful strategies I've ever found to regulate mental health. And there's data supporting that. In fact, there's a recent analysis that kind of culminated evidence of different pharmacological, cognitive behavioral therapy, so like therapeutic interaction, versus exercise. And exercise beat all of them as far as its potency in regulating mental health. And that's no surprise. And so ultimately in type 1, that's where it gets to finding consistent ways to have a normal glycemic, or having normal glycemia during exercise, or just doing things, even if you are eating food during exercise, to have the ability to exercise without making it a problem for you. But either way, exercise is one of the most potent ways, because I will flip on a dime. Where I am pre-exercise, where I am post, it's never the same, and it's always better afterwards. Always better afterwards, without question. That's the second most important thing for me. Another one that I have found very helpful is I actually did do mindfulness and meditation. It was one, and I think that's a more appreciated thing in your culture than it is here in the United States, although it's becoming more common. This discrepancy between Western and Eastern philosophy, but nonetheless, I found that was one of the most powerful things I ever did. Is I did my wife's actually done a Vipassana course. I haven't done that. I would love to do that, but I've done a guided multi-week meditation, to the point where I try to make that a consistent thing upon waking, if I can. Now I have little kids, so sometimes they wake me up at 4 o'clock in the morning, and so I can't always start my day with that. But I do find that setting my intention every single day with something like mindfulness and meditation, which everything I'm saying right here applies to everyone else too, even outside of type 1, including blood sugar control. People just don't often even know the things that they're doing affect their blood sugar control, and then don't realize how that affects how they feel, even without type 1. But yeah, the mindfulness and meditation is huge. I actually also find that if you can, and you have the resources and capability of doing something like therapy, can be very powerful as well. But in the short term, when living the day-to-day experience with type 1 diabetes, if I were to go low and I were to feel that anxious feeling, one thing I do for myself is I try to identify it. I try not to be like, oh, I'm feeling terrible, this life's unfair, and I start looking external to myself, and I'm irritated at this over here because someone's asking me a tough question, or we're dealing with a problem, and I'm low. Now almost that anger, that anxiety is channeled external. One thing I try to do is actually identify the cause of any emotional state that I'm in. So I actually try to take a moment to pause and say, why do I feel anxious, or why am I irritated at this person, or why is my anger so high? And I try to identify the origin of it. But again, the absence of identifying it, Azim, life's just happening to you. And instead, once I found is that if you identify it, you now are able to not just respond, not just react. You're instantly reacting, but now you can actually think through and respond to it, instead of just being reactionary towards it. But yeah, the biggest things by far, obviously, glycemic control, because that's just underlying biology that will challenge your mental health status every day. And so removing that constant challenge as much as you can is important, because it's just biology. It's not like I'm going to overcome super high and variable glucose levels. There's no overcoming that. That is biology, and it's going to challenge the way you feel every day, mentally and physically. That's number one. Exercise is critical. Number two, it's more powerful than any other therapeutic strategy there is that we know of in the literature. And then over here are a number of different tools and strategies that You can apply on a daily basis, whether it be mindfulness, whether it's being aware of, or meditating, or being aware of the cause of whatever you're feeling. I give myself a lot of grace when I go low. I don't sit there and say, oh, I don't beat myself up over that. I'm like, okay, I know I'm going to be anxious for the next hour. My heart rate's going to be elevated. I identify it. I say heart rate's going to be higher. I'm going to feel a little more reactionatory. I'm going to be a little more anxious. And I'm literally one by one identifying the physiology of what's going to happen. And then as a result, I feel like I'm actually able to just proceed with my day, understanding that this is almost like a part of it. It's almost like, hey, we need to do this task today, but hey, put this heavy backpack on. It's like, okay, well, I know it's the backpack that makes me feel more tired today, but at least I've identified it. I don't feel like it's my fault. I don't feel like it's all these external things that why I'm more tired. I've identified that it's this other issue. So either way, there's a ton of different things that everyone can do and have to play around with what works best. But I highly encourage people to really give those tools and strategies a go and not ignore it. And to the point where if you find that you can't do it on your own, seeking support from other people who can help guide you and resonate with guiding you on a way that it actually speaks to how you think and how you operate. And I've done therapy a number of times, and I've never regretted a therapy session I went into. I never regretted an exercise session that I did, ever. So those are things that I always find. I never regretted taking 10 to 15 to 20 minutes to meditate. So, life's busy, life's tough, but I never regret in retrospect doing those things for myself. So.
Wow.
Oh, that's awesome. Thank you. Thank you very much.
I want to be mindful, and you've given us almost 100 minutes of your day, Andrew. I see metformin and semaglutide. Rohan, so I think I'll take that question is, oh, Patrick has a question. So Rohan, I think I'll take that is, I have used metformin for some of our people with type 1 to help them with the insulin resistance, because it's almost like there's a type 2 diabetes situation going on. And it becomes hard to sometimes break out of that while you're working on things. The metformin is not a bad thing. Andrew, I don't know if you have any thoughts about that. I've avoided the semaglutide in general, so I'm not even gonna, we'll end up being stuck here for another hour on semaglutide. So I'm gonna not touch that one, but metformin, and then we'll take Patrick's last question. Thank you.
Sure. So I all I can say is what I've seen out in everyday life with people. I've actually thought about playing around with it, because most people I've seen who've taken it reduce their insulin requirements at least a little bit just by taking that alone. So that's the only comment I have on that. Semaglutide, we've actually done studies with this. And so and the literature is pretty compelling, but it seems that in the landscape of type 1, there's been very little research on this, very little to really understand what's happening. But one thing you could reliably predict is that if you're eating less food, you're requiring less insulin, and if you're losing body weight, you're becoming more sensitive over time in general. And keep in mind as well with these drugs is that it also slows down digestion. So I think I'm going to make a prediction here. What we're going to find is that people who are on type 1 with semaglutide, and we'll see this research come out in the next 2 years, that it's going to slow down the kinetics of food like carbohydrates, so that it may be more able to match the kinetics of insulin. It'll make people less hungry, so they'll start to combat some of the overeating and obesity issues that are started to rise in rapid fashion in the type 1 diabetes landscape, because most tools in type 1 diabetes to get glycemic control give more insulin. As a result, we've seen these issues arise. So it'll help with that as well. But keep in mind that it's going to slow down digestion, right? So it's just something you have to be aware of, that what that means for limitations and other things, right? So the food's not going to, if you're going to have that bread to increase your blood glucose from dropping, you might be aware that you might want to have something more rapid, or to combat that. These are things that are going to come out, because it's 100% going to hit the type 1 world the way it's hit obesity and type 2. It's coming. But I don't expect that someone can do whatever they want, just like they can't do whatever they want with AID technology or hybrid closed loop, and it's going to fix everything. You can't give semaglutide, it's going to fix everything, even though it's providing assistance. The evidence I've seen so far says that it's a lot like an AID technology, and that it's a supportive tool. It can be really helpful, but until you actually spend some effort on your own to make meaningful changes and shift around things to get glycemic control, it's never going to be the golden ticket. And so So either way, that's what I see coming for semaglutide, and it's a valuable tool. I mean, some people, reducing calories, man, is I know because I was obese, and I failed for years to do it. And I my family was like my family were ate right, and exercise all the time. I had all that available to me, and I still struggled for years. And so having a tool like that can be so powerful in assisting people who really, really struggle on that path, but also understand that you are going to have to take control to really allow it to really work well. And keep in mind, just like with type 1 diabetes, it will never work forever unless you're on it forever. And so what I actually feel a little grateful for is that if I had obesity at that stage and GLP-1 was available, I would have instantly taken it. But instead, I was forced through years of struggle to find something that allowed me to maintain it while not feeling hungry all the time, while not struggling with all these other facets of my life. And so it forced me to try to find a normal lifestyle pattern that didn't require chronic pharmacological intervention, that allowed me to feel a little more, to achieve that in its absence. But there's nothing wrong with doing that. I mean, we're all, anyone with type 1 has a lived experience of how revolutionary medication is. We wouldn't be, frankly, living here without it. So nothing against it. It's just be aware of the limitations.
I appreciate that response. I'm glad you did touch on it because it was useful to hear you say it that way. I worry about the muscle loss with semaglutide. And like you said, you have to stay on it as long as you want the benefits. But let's see what comes up in the type 1 world with semaglutide. Amazing.
Keep in mind that most of these weight loss studies, you can almost eliminate the entirety of any muscle loss during a caloric restriction, like it's even severe caloric restriction with resistance exercise, and also with a high protein based diet. So we have no nutritional guidelines right now for people on obesity or type 2 diabetes on semaglutide. But the most obvious approach is to consume essential nutrients, which it means essential amino acids and essential fatty acids, as the cornerstone of the nutritional strategy. And obviously protein assists with maintaining muscle mass. But just to be clear, people talk about protein as if it is a miracle for muscle mass. It is not. Exercise is what actually maintains and builds muscle mass. Protein probably adds like 2% to that, maybe 3%. It's meaningful. It's honestly I have a protein focused diet. It obviously does matter for exercise response and otherwise, but just keep in mind, the real thing that's actually keeping that muscle mass and maintaining it is the work, lifting weights and actually exercising. That's what does it. It's not the protein that's doing it for you. In the absence of exercise, protein does very little at all. It only helps. It helps exercise. It helps maintain it. So you have to have the exercise as a critical part of it. And protein does very little in the absence of exercise.
Amazing. Wow. I think we could stay here all day. Last
That's
question.
amazing. I can do this multiple times over. This is great. I actually have a blast with you guys.
Yeah, you've been amazing, Andrew. It's such a knowledge base, right? So many angles to everything, and it's complex what we've tried to cover today. So we're obviously not done. Patrick is here from Nairobi, Kenya.
Cool.
Yeah. Thank you so much, Dr. Roshni, and thank you, Andrew, and the team that's listening. Sorry, I joined a bit 5 minutes late. I have two basic questions. Number one, to Andrew, what would be your recommendation in terms of how much walking or running does one have to do on daily basis, or by maybe 2 or 3 times a week to be able to exercise fully? Because my personal experience is walking and running helps me burn more energy, and actually I feel much more fulfilled as going to lift weights in the gym. That's my personal experience.
I'm really glad you asked the question. The amount of exercise, so that's all based on general health outcomes. So it is true when you say you feel better when you run or you do like aerobic exercise. There's actually a lot of data on the cycle or the neurobiological benefit of exercise from a cognitive perspective, from aerobic exercise specifically over long durations of time, or shorter durations of time but much more intense, like high intensity interval training can also activate that. From a weightlifting perspective, keep in mind you can do it a number of different ways. You don't have to just like pump out a super like heavy set and then sit down for 3 minutes. You could do that, lower the weight a little bit, do that, and then rest like 60 to 90 seconds or less and keep the intensity higher, because what they actually find is some of the cognitive benefits, a lot of what you're describing, you feel better mentally. A lot of that actually comes from this shift, this change in the brain. And they also have seen that these cognitive improvements are actually highest when people do endurance strength training, which means like very high intensity type of almost weight resistance style work for a period of time. Let's say it's almost like a weighted rock. If you've heard of that before, where people, it also kind of got famous in the fitness world for a period of time, where you put on these really heavy backpacks and do intense exercise. We used to do those actually in at altitude in hypoxia settings. We put these massive backpacks on and go directly uphill.
Trucking.
But you can just do fast, rapid forms of strength training. I will also resonate with you that when I used to do hardcore powerlifting, where I was just trying to like squat over 500 pounds, deadlift over 500 pounds, and bench close to 400, like that's all I cared about. You had to take really long breaks in between to really get the maximal strength. And I would walk into the gym and walk out like 3 hours later, and there would be no change in my insulin sensitivity, because I was basically like taking a nap in between each set. It was like, it wasn't actually doing much to my overall prolonged elevated heart rate, because my heart rate would come up and come down and up and down. But that prolonged elevation in heart rate is where you really start to see a lot of these metabolic benefits over time. And endurance exercise is very unique in that it basically guarantees that. By structure of an endurance exercise bout, when you walk or run, you're elevating your heart rate sustainably for a period of time, hence why you're starting to see those effects. But in strength training, you can do the same thing if you shorten the rest periods and make it more of a kind of higher intensity, elevated heart rate with less rest in between type of exercise. That's what, in essence, CrossFit has tried to do, which became very famous here. And I think that it's a remarkable way. It's done more to help people lift weights than virtually anything in America has. However, you just got to do it safe, right? I don't know if, slinging around max effort, squats or deadlifts or, snatching all the time in super rapid fashion may be the safest thing. But if you lower those weights and you lower the rest period, you can get very similar effects. Then to answer that question in a more broad sense, the more exercise you do, the better the health outcomes appear to be over time. So the minimums people try to achieve for is like 30 minutes a day, or the what they call American College of Sports Medicine. Their guidelines say to exercise do resistance exercise, 2 to 3 days a week, and or aerobic exercise 3 to 4 days a week. At least that was at one point their guidelines. The reality is that you should just be trying to engage in both forms. You should be doing aerobic exercise and resistance exercise as often as you can for as long as your lifestyle allows you to. And all the evidence essentially says that the more exercise you're doing, the more benefit you're going to get in almost every aspect of life, whether it be mental health, whether it be reduction in comorbid disease incidence, all-cause mortality. All of those go down with the more you do of it. So that's the important take-home message of that is just do what you can as often as you can. And I often recommend people to just start, if they don't have anything that they enjoy doing, because if they think, well, I need to do this perfect prescriptive exercise that I saw someone doing on Instagram, that's not the way to start. Where you start is saying, hey, I like going for walks every day. Excellent. Do that. And then do a little bit more of it. Then make it a little bit harder. Then And you progress over time, and you're becoming fitter and fitter. Your body's becoming stronger. You're able to tolerate higher levels of stress. That's actually how exercise makes us stronger and fitter, is you're inducing a short-term stress. Your body's adapting to it. And now you get stronger. And so what happens is you're doing this over time with that stress. You have high intensity exercise, your body's rebuilding, and then you're stronger the next time. And you keep going. And over time, your body's has a stronger heart, a stronger vascular compliance, blood vessels, and beyond, right? So that's the whole principle of exercise.
Secondly, what would be your advice on the use of sweeteners, especially the low-carb sweeteners, because sometimes it's very difficult, and this is human. Dr. Roshni would help us understand that. Sometimes you feel like maybe you test a sugar cane once in a day or once in a week, And you find yourself when you're taking tea or coffee, you just need something to make you feel, just to activate your nerves, nothing to do with the body, but you just feel like your brain feels like you need something sweet because you're coming from that background.
Now, when you mention sweeteners, there are a number. There are many artificial sweeteners and non-artificial sweeteners. As a general rule, there are some notorious artificial sweeteners like sucralose that we now know has evidence that suggests that not only is there was a bunch of evidence in animals for a long time that it may be causing insulin resistance, and now there's human evidence that says that things like sucralose may be inducing that. I'm still hesitant to believe that someone should consume real sugar instead of any of these artificial sweeteners, right? Because at the end of the day, if you're consuming real sugar, those are real calories that induce elevations in blood glucose levels. And ultimately, you have to manage that with insulin. So you're having glucose, insulin, and calories. Replacing that with an artificial sweetener and keeping everything else the same is almost certainly a net win because you're consuming less calories. You're not getting that blood sugar flux. You're not getting the insulin. But that's relative to if you were to have something like pure sugar. So that's how I view sugar versus artificials or natural sweeteners. Now let's talk about the category of sweeteners in and of itself. The artificial types are the ones that typically are like sucralose, aspartame, saccharin. These type of sweeteners tend to be the ones in the literature that have potential negative data around them. We're like, okay, yeah, they reduce calorie, or they supplement things like sugar and they give you sweetness, but there's this study over here in animals where they consumed it over time, they got insulin resistance, or this or that. And so it's a lot of it hasn't translated fully to humans, except for sucralose. That definitely has. That has translated to showing signs of insulin resistance in humans. So I would avoid that at all costs. Because you have other options. Why not choose one that it gives you that sweet flavor that doesn't have that negative potential effect? And that's where you get into the category of which are much less studied, but just seem more logical. And I'm being honest when I say that we don't have a ton of data around these, but we have to use some type of logical, educated steps, right? In the absence of evidence, it doesn't mean that you shouldn't do something. It just means you have to use the evidence we do have and make an educated, informed decision. The natural sweeteners are stevia. They come from leaves. Monk fruit, I think they come from fruit. And there's allulose. Allulose comes from like figs and other forms of fruit. Of those three, all of them do not raise blood sugar level. There's also erythritol, but that's kind of an artificial one. But either way, so we'll focus on those three: stevia, monk fruit, allulose. Stevia seems like a great option for most people. I certainly respond really well to it. I enjoy it. It has a different flavor than sugar does. So it's not, it's usually in liquid form. Be careful about packeted form. In the packeted form, stevia comes in a liquid. So in order to make it a solid, a lot of companies actually attach it to a sugar, a maltodextrin, which is a sugar. It actually converts to sugar. So when you have a packet of stevia is so much more potent than sugar that you need less of it. However, it's still attached to a maltodextrin. So if you can do stevia, probably best to do it in the liquid form. If you can, if you're going to have the packeted form, I would be just judicious and limit the amount you're going to have. Then you have monk fruit, which seems like a great option. It's in a lot of foods. It's not really as commonly available in isolated form like stevia is. You can go to a lot of markets, at least here, and buy that off the shelf. Whereas monk fruit, I think you have to go to very specialized stores here to even get access to powdered form of that. Allulose. This is actually the most interesting one to me because I am about to publish a study coming soon on allulose. Allulose for a long time, I believe for about a decade, was a very neutral, non-glycemic sweetener that is in powdered form, does taste like sugar, and has about 70% of the sweetness of sugar. So it's like a really good supplement for real sugar if you want to use it for baking or other things. That doesn't have the calories. However, I just thought it was like something that was non-glycemic, no glucose effect or no insulin effect. When coming to find out, there is a lot of evidence in rodents that if you were to so what allulose is it called a C3 ephemer fructose. It looks just like fructose, but when you flip one of the bonds of the molecule, it makes it largely non-digestive. So you don't actually get the glycemic response, but you do actually get a lot of the incretin responses that have positive metabolic effects too, as if you had consumed something like glucose. Now, glucose isn't, when you consume glucose, blood sugar goes up. But imagine you consume glucose and have some of the similar metabolic effects without blood sugar going up. So what does that mean? Well, it stimulates endogenous GLP-1 production or secretion. It also appears to lower glucagon in animals. And the GLP-1 elevation has been confirmed in humans. So you consume allulose, it actually increases endogenous GLP-1. It has been shown in 2 separate studies in obese patients and patients with type 2 diabetes that consuming it with a meal can blunt the blood sugar elevation of a carbohydrate-based meal. And that's probably due to some emergent evidence in they say gastrointestinal models, these models that allow us to look at how food is digested in the gut, by a gentleman named Nick Bellissimo, who I'm good friends with. He showed that it actually slows down the enzymatic breakdown of carbohydrates. So it appears that it is not just a neutral sweetener, natural sweetener. It actually appears to have metabolic benefits that extend beyond stevia and monk fruit. At least that's what the evidence says thus far. And I actually have done a study that will be published soon in the context of type 1 diabetes, where we actually gave something called a mixed meal tolerance test, where you're actually consuming a whole food-based approach that's over 55% carbohydrates, basically a standard high carbohydrate-based meal, and with or without allulose. And it dramatically reduced the glycemic elevation and insulin needs. And then when consuming it with meals all day, it also reduced the glucose and insulin requirements throughout the entire day. And so I don't believe allulose is inert. I actually am starting to believe it has positive metabolic benefits. And so I find that a very interesting molecule. I use both. I use stevia and allulose, just being totally frank. So to each their own and what they find valuable, what they want to use. But those are the 3 I stay away from almost everything but stevia, allulose, and monk fruit. And just like your question brought up, is I'm also a little careful, because whenever you're consuming any type of sweetness, it does give you that positive feeling, like that, boom, I feel great. But that positive feeling also comes with a feeling sometimes of, I want more of that. And so one problem I have is if I were to add like stevia into coffee, I'm like, man, I want like 5 of these, and so I have to be a little careful with those, because for periods of time, I've actually cut out all natural and artificial forms of sweeteners, and it dramatically reduced my overall hunger almost completely. And what it taught me is it doesn't matter if it was real or not. That's that positive sweetness. The sweeter it is, actually, the more the hunger response is as a result of that. And that's just not my lived experience. That's actually scientifically based. So it's amazing to have. It definitely certainly helps. I use them still today, despite knowing all this. It's just be careful, because nothing's for free.
Wow. Andrew, you have given us 2 hours nonstop. We've been shooting questions at you, and you've been just generously like sharing so much knowledge. You are like an encyclopedia, and we need to get you back. And I think we're going to.
I'd love to come back. This is a blast for me. I very rarely have the opportunity where people genuinely just ask questions ad libitum like this. This is honestly genuinely extremely fun. It's you can sit in a like an office or a lab or something like that, and you lose touch with reality sometimes. And that's why the lived experience with type 1 is so important to me. But actually engaging with people and actually sharing the knowledge is the only reason I even went into this field. It's the only reason I studied diabetes, is because I found it fascinating for myself. And then I went on to realize how tragic it was that other people didn't have the same information. And that's why I've actually become more public and started to speak out more. It's not necessarily my favorite thing to do, to post on Instagram all the time, I'm being honest with you, but I only do it because I've had moms reach out to me and say, my son doesn't feel he can do this, or I don't know why this is. And so I'm trying to be more, put information out there more in hopes that it helps people. So yeah.
Yes, I can say I'm in the same bucket. As social media is awkward. I like, connecting to people like this, but it's the same feeling as we put it out there, and then just 1 or 2 people come and say to you, keep doing those posts. You might find it's drag and it's awkward and you don't want to put yourself out there, but it's actually helping us. And your posts help us, help me, and it gives us inspiration. So thank you. I think this audience benefited a lot. I learned from you today, and we'll bring more questions and we'll do more Q&A whenever you have the energy, and we'll call you back.
Okay. I got the energy. So you just let
Okay.
me know when you guys want to do this. We can set something up.
But we'll put up the recordings, and that way it's there for everybody.
Cool. Yeah. Honored to get to speak with you guys today, especially if you guys are across the world and whatnot. It's pretty cool to have the opportunity to connect with you guys. I'm sorry it's so late though.
Yes,
I suspect it's real late over there now.
No, yeah, it's 10 o'clock, but everybody's stuck because you were sharing so much. We've learned so much. So thank you, Andrew, for your time. Thank you.
Honor to be here with you guys. Honestly, appreciate it.
Okay. Have a good day.